a shortness of breath that occurs no matter what you're doing, a continuous dry cough that follows you wherever you go, widening and rounding of fingertips and toes. These are just some of the common symptoms of idiopathic pulmonary fibrosis. Idiopathic means the cause of the disease or condition is unknown. Pulmonary specifies the lungs, and fibrosis refers to a disease where tissues become thick and stiff, essentially forming scar tissue called fibrosis. Though the cause of this disease remains unknown, IPF is usually characterized by interstitial pneumonia, or infection of the walls of structures in your lungs called alveoli, which results in a shortness of breath and a continuous dry cough. Published literature suggests that IPF is one of the most common interstitial lung diseases, usually affecting middle-aged and older adults. Today's video will further describe IPF by 1. Identifying common risk factors, 2. Elaborating on various diagnostic procedures to determine the presence of IPF, and 3. Treatment will briefly be mentioned. As an incurable disease with a 50% death rate 2 to 3 years following diagnosis, an accurate and early diagnosis during disease progression is important, as severe final stage complications can result in respiratory failure, pulmonary hypertension, and heart failure. Some common risk factors to be aware of that are associated with this disease can be classified into 3 main categories. 1. Inhaled exposures, 2. Gastrointestinal comorbidities, and 3. Genetics. Multiple lines of evidence suggest that inhaled exposures via smoking, the environment, and occupational circumstances contribute to some cases of IPF. These potential agents contribute to repetitive stress on the cells of the lungs. Epidemiological studies further depict that higher rates of IPF incidence are seen in regions that are more industrialized, where men are more likely to smoke and work in dustier conditions, and where inorganic particles such as silicon and aluminum accumulate, as they are frequently found in the lymph nodes of IPF patients. Further evidence suggests that gastroesophageal reflux disease, GERD, is hypothesized to be linked to IPF. This disease causes chronic microaspiration of gastric contents, resulting in lung injury and pulmonary fibrosis. Various animal studies depicted a 67% or higher prevalence of GERD in subjects with IPF. Familial IPF is rare and found in less than 5% of all IPF patients. However, in some cases, mutations associated with familial IPF are commonly found in telomerase-related genes, the mucin5B gene, and surfactant protein C. Though research is still inconclusive, most mutations are thought to be associated with problems involving host defense, cell-cell adhesion, and DNA repair. In order to diagnose IPF, it is critical to examine medical history, physical examinations, and various other diagnostic test results. Physicians will commonly look for the following results. Most patients will have fine bibasilar inspiratory crackles, 25 to 50% will display clubbing in their digits, and 20 to 40% have pulmonary hypertension at rest. The basic diagnostic procedures include a chest X-ray, a high-resolution computed tomography (HRCT), echocardiography, and the gold standard diagnostic technique, a surgical lung biopsy. Though lung biopsies are most accurate in determining the presence of IPF, they are an unrealistic and invasive method to apply to all potential IPF cases. In a study published by Roland M. Boyce, HRCTs are described as the next best diagnostic method following lung biopsies. This paper describes a diagnostic algorithm that accurately identifies usual interstitial pneumonia patterns, allowing for the diagnosis of IPF. In 2011, various American, European, and Japanese respiratory and thoracic societies issued basic recommended guidelines on steps to diagnosing IPF. Step 1. First, suspected IPF patients should be carefully evaluated for identifiable causes of interstitial lung disease, ILD. Step 2. In the absence of ILD, an HRCT should be administered where any usual interstitial pneumonia patterns are diagnostic of IPF. Step 3. In the absence of a pneumonia pattern in the HRCT, a combination of specific HRCT, histopathological patterns, and lung biopsies can be used. Early diagnosis of IPF is crucial for improved prognosis of this disease. It allows therapy to be implemented earlier using anti-scarring medication such as pirfenidone and nintedanib to slow the progression of IPF. These therapeutic drugs are found to be effective when treating patients with mild or middle stage IPF. Though a definite cure for IPF is yet to be discovered, it's important to regularly visit your physician if IPF is suspected in order to receive the proper diagnostic and therapeutic measures available to you. To learn more about IPF, and if you like this video, please like and subscribe to our Demystifying Medicine channel.